Okay, let's just jump right into this explainer. We're going to look at a super high-stakes emergency room scenario today, walking through a case involving a 35-year-old mechanic named Hassan. And we're going to use his story to truly understand the split-second decisions and the incredibly precise protocols of modern trauma care. If you've ever wondered how emergency teams actually bring someone back from the absolute brink of severe blood loss, well, this is exactly how they do it. So the whole thing starts in a busy garage. Hassan suffers this massive, honestly terrifying, crush injury where he's pinned between a wall and a reversing van. The clock instantly starts ticking. Now, when the paramedics arrive, he's conscious, he's talking, but he's complaining of severe lower abdominal pain. Right off the bat, the paramedics suspect a possible pelvic injury. And this is a crucial detail because the pelvis can hide an enormous amount of blood. Right, so in this pre-hospital phase, time is literally everything. Paramedics do this lightning-fast 5 seconds round, quickly noting his social interaction. He's talking, so that's good. His respiratory effort is normal. But his skin? It's pale and clammy. Now, thankfully, they don't see any massive external bleeding, so they immediately focus on airway management, spinal immobilization, and just getting him safely transferred to the ER on high-flow oxygen. Okay, now Hassan rolls through the ER doors, and honestly, chaos could so easily take over. But to stop that from happening, the medical team relies on the CABCDE approach. This is basically a universal mental checklist. It's a highly structured methodology to systematically hunt down and treat life-threatening injuries in polytraumatized patients. It makes sure absolutely no one gets distracted by a dramatic but minor injury while missing a fatal hidden one. And what we're looking at here perfectly illustrates the golden rule of trauma. Authoritative bodies, like the Egyptian Health Council, are super clear on this. The time between the injury and getting the bleeding under control has got to be minimized, at all costs. This is a strong, definitive recommendation. It means immediate local compression of open wounds, or even slapping on tourniquets for extremity injuries way before surgery. You literally have to stop the leak first. So the ER team starts Hassan's primary survey. A for airway, B for breathing. And, things look kind of deceptively okay at first. His airway is clear, he's talking and obeying commands. His breathing is a little fast, sure, but his oxygen saturation is 94%, and crucially, an ultrasound of his chest is totally normal. They've basically ruled out major issues above the diaphragm. But wait until we get to the C in the protocol, circulation. It's about to tell a completely different story. Because here is where we hit this terrifying paradox. Remember, we didn't see any massive external bleeding earlier, right? But just look at these vitals. His heart rate is spiking at 112 beats per minute. His blood pressure is totally crashing, 86/65. And that capillary refill time, you know how long it takes color to return to the skin after you press it? It's a really delayed 4 seconds. Basically, his entire body is screaming that it's rapidly going into shock. So the team has to play medical detective. They start piecing together the physical clues. Hassan has abrasions on his lower abdomen and pelvis, extreme tenderness, and blood at the urethral meatus. And then the ultrasound confirms the hidden threat, a positive pelvic fluid collection. The diagnosis is absolutely locked in. It's hemorrhagic shock from a severe internal pelvic injury. He is literally bleeding out on the inside. To stabilize him, they immediately fire off a specific sequence of actions. Keep that high-flow oxygen coming, get 2 large vascular access lines going for fluids and blood, and hook up the ECG monitoring. But step 4 here? This is the absolute game changer. They apply a pelvic binder. If this wasn't already done in the field, it has to be done now. This mechanical compression physically limits the space the pelvis has to bleed into. They are buying him time. Now, with his vitals completely plummeting and this hidden internal threat clearly identified, the ER doctor has to ask the single most critical question of the day. Do we activate the major transfusion protocol? Activating this unlocks massive hospital resources and taps heavily into blood bank supplies. It's a huge deal. You definitely do not make this call lightly. Well, to answer that, they look straight at the strict clinical definition of a major hemorrhage. Does he have an estimated blood loss over 1,500 milliliters, or 30% of his volume? Yes, definitely, given that pelvic injury. Does he have hypotension, meaning a systolic blood pressure under 90 and a heart rate over 110? Yes, he hits both of those markers too. Hassan clearly meets the criteria. So the smart move here is using predictive, evidence-based tools to actually justify this early activation. They use something called the ABC score, the assessment of blood consumption. You get a point for a high heart rate, a point for low blood pressure, a point for a positive fast exam, and a point for penetrating injury. A score of 2 or more mathematically tells you to pull the trigger on the massive transfusion protocol. alongside checking his shock index. The math is basically saying Hassan needs blood and lots of it. Now, here's where the medical strategy might genuinely surprise you. It's totally counterintuitive. The goal actually isn't to pump Hassan full of fluids until his blood pressure is perfectly normal. Nope. As the guidelines strongly recommend, they use a restricted volume replacement strategy, which is sometimes called permissive hypotension. They are aiming for a much lower systolic pressure, specifically around 80 to 90. Why? Because if you pump that pressure up too high before the surgical team fixes the leak, you'll literally blow out the fragile clots his body is trying so hard to build. You'd make him bleed even faster. And, when they do use fluids to maintain that careful low-pressure balance, picking the exact right fluid is absolutely key. The strict recommendation here is to use balanced crystalloid solutions like 0.9% sodium chloride or Ringer's lactate. They explicitly suggest restricting the use of colloids. Why? Because colloids can dangerously interfere with the body's natural blood clotting processes. And honestly, that is the absolute last thing you want in a hemorrhage patient. This whole delicate balance thing extends right down to the actual blood products they're using. Because a massive transfusion isn't just pumping in a bunch of whole blood, it's a highly precise recipe. Packed red blood cells restore that vital oxygen delivery. Fresh frozen plasma replaces the coagulation factors he needs to form clots. Platelets are brought in to physically plug up those bleeding vessels, and they're targeting a count over 50,000 for that. Plus, cryoprecipitate replaces the fibrinogen, which is basically the glue holding those clots together. Every single component has a very specific, balanced job. Now, because this situation is moving so fast, just taking one blood test is nowhere near enough. In fact, an initial, perfectly normal hemoglobin reading can completely trick you. It can mask early massive bleeding simply because the body hasn't had time to dilute the remaining blood yet. So the protocol demands continuous, serial monitoring every 30 to 60 minutes during resuscitation. And once they finally get that bleeding source controlled, the survival target is to maintain that hemoglobin safely between 7 and 9 grams per deciliter. But here's the crazy part. While they're laser-focused on managing his blood, another silent killer is sneaking right into the trauma bay: hypothermia. When a patient is in shock, totally exposed and getting rapid fluids, their body temperature just plummets. And this is disastrous. It essentially freezes the blood's chemistry. It leads to worsened coagulopathy, which is basically a total inability to clot. The platelets become totally dysfunctional and mortality rates just absolutely skyrocket. So to fight this cold reality, the protocol employs highly specific clinical warming solutions. Hospitals actually use these specialized thermostatically controlled cabinets. They store the fluids so they're ready to use between 40 and 46 degrees Celsius. But, as we all know, fluids cool down once you take them out, right? So they pair them with inline fluid warmers. These are these ingenious little devices that continuously heat the specialized tubing right during the infusion itself. It guarantees that every single drop of life-saving liquid going into Hassan's body is safely heated. Now, through all of this chaos, the medical team is constantly hunting for proof. They need to know that what they're doing is actually working at a cellular level. And that brings us to this specific number: a serum lactate level greater than 4 millimole per liter. This is the ultimate red flag. It indicates severe shock and dangerous tissue hypoperfusion. Simply put, Hassan's cells are starving for oxygen, and they are crying out for help. Since a normal baseline lactate level should be somewhere between 0.5 and 2, serial tracking of this number becomes the truest test of whether he's going to survive. The team checks the baseline, and then they just keep monitoring it. If those lactate levels start decreasing, that is a glorious sign. It proves that oxygen delivery is finally improving and blood is making its way back into Hassan's starving tissues. But if it stays elevated, well, that means the hidden bleeding is still winning. So ultimately, what this explainer really shows us is that trauma care and emergency medicine isn't just about rushing around a room with sirens blaring. It's about mastering an incredibly structured, highly delicate balance of biology, chemistry, temperature, and time. Every single intervention we just walked through represents a split-second decision designed to pull a patient exactly like Hassan back from the absolute edge. So I'll leave you with this to think about. The very next time you see an ambulance rush by, consider the invisible, perfectly orchestrated science happening inside. Could you master that balance when every second counts?